Welcome to the MCM Student Business Show hosted by Dr. Kevin Christie and Dr. Gage Winkles, with a special clinical segment by Dr. Mark King. The show for chiropractic students and recent graduates, designed to help you become a thriving chiropractor.
All right, Kevin, so episode 3, question 1 regarding business here. Question submitted was, as an independent contractor who does not pay rent, should I be concerned that the clinic owner is taking 50% of every patient visit I have?
Okay, yeah, so let's dissect that out a couple of different ways. So they mentioned independent contractor. So I'm going to take this as, and this will just be United States based because Canada and different countries are different. You're going to have a 1099, which is an independent contractor versus an employee is a W-2. As an independent contractor, and if that's what it is, let's just say that's fine. Usually it's not the case, but if you're an independent contractor, you still should be okay with the owner doctor getting 50% on that, because the reality of it is as practices grow, very few owner chiropractors are taking home 50% themselves in their practice. Overhead is high. There's a lot of things going on there, but a lot of times they're taking 25, 30%. And so even the owner isn't taking home 50% of what they treat. And they're probably not even taking home 50% of what they treat, and including the profit and revenue that independent contractor is breaking in. It's very, now if you hear a chiropractor that is, a lot of times they're early on and the overhead's really low, but the revenue's low as well. So there's this, a lot of times, an inverse relationship between revenue. Like if I took $1 million practice, the owner is probably taking a lower percentage of that, but that lower percent, let's just say it's 25%.
Yep.
That's $250,000 a year is income.
Right.
That's a good absolute number of income, right? Then a lot of times you'll hear clinics that are bringing home 50%, and they'll kind of hang their hat on that. And that's fine, but you look and the revenue is $175,000 for the clinic,
right? And
so that is, about $90,000. Right. And so would you rather have 25% or 50%? I don't know. What's the revenue? What's the overhead? There's a lot going on to that. But to answer the question, as an independent contractor, you should be okay if it's a 50-50 split. If you're getting 40%, you probably should be okay. But fight for what you can.
Right.
But I wouldn't hold it against the owner if they're getting 50%, because the overhead is high. There's a lot that goes into it. There's even risk with independent contractors. If we were to answer this question as a W-2 employee, it's a whole other animal, because I'll just get into it a little bit, where now that owner doctors also paying employers' taxes of about 10% also. So if you're on a 50-50 split, the owner is 10% is gone, so it's 40% now for the owner. Then there's other costs, so that goes down, and then there's overhead, so that goes down, and so now you got a situation where a lot of times in those situations the owner is really maybe taking home 20-25% of that split, and the W-2 associate is 50%. So there's more to it than just the numbers.
Right.
But for the sake of this question, as an independent contractor, again, negotiate and fight for what you can, but you should be okay. You shouldn't be upset if it's a 50-50 split.
Okay.
All right, our first question, what are your strategies with cervical disc herniations with radiculopathy?
Well, we're here to talk a little bit about cervical disc patients, and these are patients you're going to see quite regularly in your practice. So this is an important area for you to be able to manage, because these people need you. So you start off with a good history, of course, and a lot of times these patients are very uncomfortable in the office. So they'll be squirming around a little bit. They may not be well rested because they may be struggling to get comfortable to sleep. So those are important issues. I don't want to leave this sleep point too quickly. If they're not sleeping, I always think about it this way. If you take a prisoner of war and they want to torture the prisoner, what do? They deprive them of sleep. So that's one of the things, right? So if your patient's not sleeping, you need to get them some help. So as much as you may want to be drug-free, those are patients who may need medications temporarily. So you can have some time to work on these patients, because if the pain's too severe, they're just going to leave your care and go get help anywhere they can. So if you have to tag team this for a week or whatever to get them, maybe their family doctor prescribes a Medrol dose pack or something, just to get them through that initial severe stage while you do your good work, that is important. So once you get through that initial history and what's going on with that, you want to do the thorough exam. You do your neurologic exam that you learn in school. There's a few tests that are going to jump out much more commonly than others, and including triceps resisted muscle testing, triceps deep tendon reflex. The Cody sign is a common one that is the patients with a cervical radiculopathy will have. And then other stuff you can do with end-range loading, cervical compression testing, distraction, all those things are part of it. Imaging, if you have x-rays or if you have an MRI that's been done, and so on. So these are all part of the test you do. And you need to, I think, because you're going to see this a lot, you'll need to get very good at this, and then you need to be able to do it efficiently from a time standpoint. So you want to get in there and do your exam and be able to know what's going on, because these patients, again, are so uncomfortable. They need you to get to the point. Okay, Mr. Jones, you have this cervical radiculopathy, and you talk about it to the layperson, a pinched nerve. They don't know what radiculopathy means. And they may have a lot of trouble concentrating on what you're saying if they're extremely uncomfortable. So you want to be short and sweet to the point that that nerve is truly pinched. Most cases are not true radiculopathies, right? But there are true radiculopathies that you're going to see on a regular basis. And you need to get the process started to try and get these people some relief. So I get these people often on a treatment plan right away that's aggressive. A typical would be 3 times a week for 3 or 4 weeks, depending on kind of their age and some other factors. The disc herniations tends to be a relatively younger crowd, whereas stenosis tends to be the older crowd. And you need to distinguish whether this is a mechanically driven problem, meaning joint dysfunction and functional weakness, or if it's really a chemical problem or a combination. Most commonly, it's a combination. But they can be chemical, meaning they're going to respond well to anti-inflammatory treatment, whether that's curcumin or whether that's prednisone or whatever it might be, to try and reduce that inflammation. But you need to kind of categorize these patients as best you can. For those MDT people out there, that's one of the things that MDT does so well. They put them in a category, and they say they respond to this movement, so that's going to be their take-home to try and get some relief. You don't have to do MDT. I mean, people have been treating these cervical disc problems for forever without using MDT, but I'm just saying that's one of the tools that you can use that can often be helpful with these conditions. Now, one of the problems with end-range loading is a lot of these patients lack upper thoracic extension, so that the adjustments are going to tend to be directed toward that upper thoracic CT area. So one of the questions you get all the time is, can you adjust somebody with a disc herniation? And the answer is absolutely yes. It's when you go to start to adjust them, though, is that increasing their radiculopathy. Again, if you're an MDT person, if you're doing end-range loading and their arm pain is getting worse, what does that tell you? Well, that tells you that's not the right direction. So if you're setting them up to do a cervical adjustment of some kind or upper thoracic adjustment, they say, yeah, my left arm pain is increasing, well, then you need to back off. That's not the right adjustment for them right now. And maybe you have to go to the other side or below that or above that, or maybe they're not ready to be adjusted that day. So I just don't force the issue, but I do know that I can adjust and do adjust these patients every day. And a lot of your patients have a disc herniation, you don't even know it. But the point is that these are acute radiculopathies. You know that they have this radiculopathy, and they need treatment, and they need to get started now. If they're severe enough, I'll even treat them every day for several days in a row. But I put them on a care plan. If they need medication to get through the horrible stage, I will get them over to their family doctor, to a neurologist or a neurosurgeon or somebody, depending on what city you're in and who's the best person for them to see. Get them on the care plan. A lot of people will use traction, they'll use end-range loading, they'll use any modality they can to kind of get the process started and get the healing going. And then we are the absolute best people for them to see. And then if they fail conservative care, you do it, for example, do a 3-week trial, excuse me, how they do it. If they're getting better, then keep going. If they're not getting any better, then you darn sure better be getting x-rays and MRIs and a surgical consult, because they won't last too long with an acute cervical radiculopathy if it's not showing some improvement. They just can't take it because they're not sleeping, they can't focus, they can't take care of their kids, or they can't work, and so on. So put them in the category, start doing your adjustments. Typically, the area of herniation is not going to be the primary fixation, because that's often the area that is, taking too much motion, say C6, C7, for example, and maybe you're adjusting T2, T3, T4. That's a common scenario. And the upper thoracic area is the fixated area, and maybe they have forescapulous stabilization, so you can add that to your routine too. So I don't mean to jump all around here. I want to be very specific. You do the history, you've got to listen to what they're saying, because if they're in really severe pain, you've got to get the party going and get some treatment going, and sometimes that means even medication. Put them on a care plan. After you do your really good exam, figure out what's going on, put them on a care plan. Don't hesitate to get x-rays and MRIs if you feel like that, if the condition is getting worse, if they're not improving with your treatment. Don't hesitate to get that other diagnostic testing done. As we did, if you have a super confusing case that's down the road, you may do an EMG, NCV. But anyway, you have on your treatment plan, you're treating them with your best stuff, your adjustments, your low-tech rehab. If you're MDT or if you have cervical distraction, those are kind of classic examples of what people do, and start treating them. And again, I want to emphasize, you're the best person to help them. And as much as I like to use natural anti-inflammatories like curcumin and fish oil and so on, sometimes they need something initially stronger to get them over the hump, so they can at least be in a state they can tolerate it, so they can continue to do their treatment. So do your best to help these patients. If they don't, make sure you have a good spine surgeon you can refer them to, or a PM&R doctor, neurologist. That can, maybe they have to do an epidural or a stronger medication, but have that referral network set up in case they don't respond to your treatment.
All right, Kevin. So episode 3 here, question 4 regarding communication. Do you have any advice for introverts who have to talk to many patients all day long?
Yeah, that's a hard one.
Yeah.
I'm introverted by nature. I guess there's that middle one, which is ambivert. I can definitely talk to people, but it doesn't give me energy. Mm-hmm. And extroverts, when they talk, it gives them energy. Introverts, it drains them. My recommendation would be, and what I found in 20 years of practicing, is that it is a real thing, right? At the end of a day, I can be pretty exhausted because of all the conversations, and it can impact your personal life if you're not careful. But what I've found was that some of your patients, you're going to enjoy talking to, and it doesn't drain you, right?
Right.
And then there's going to be some patients that are, in the middle, and there's going to be some that drain you. Just like you see them on the schedule, you're like, oh. Right. My recommendation would be is start to get clear on knowing which ones give you some energy when you do talk to them, good conversations, and have those conversations. If it's someone that's in the other two buckets, one of the strategies I've done is just ask them questions often and let them talk.
Yes.
Right?
Yep.
That's definitely something that you can do, is just get good at asking questions and letting them talk. Because sometimes, as you develop this, you realize like that person likes to talk a lot. Mm-hmm. I'm not that interested in talking to them a lot. I need to conserve it, but I'll just ask them questions and they'll go on talking.
Right.
You get some people, they don't want to talk, and frankly, they don't want to hear you talking either. And you got to know that as well, and use that as an opportunity. Maybe turn the music up a dial and just listen to some good music.
Yep.
But my overall recommendation there is to ask more questions and listen. Give yourself some breaks on that. And then when you do have that patient that you enjoy the conversation with, do that, and take it seriously, because it is a challenging part of what we do. But I like to look at the positive of it. Very healthy to have a lot of conversations and relationships, and I think it's one of the benefits of what we do for a living.
Absolutely.
And so take that as a positive. The folks that are struggling in life right now, a lot of times, they're working from home, they're behind a computer, they're not talking to anybody other than maybe at the end of the day their significant other or their kids, and they're getting no social dynamics in their life outside of that, and that's not good either. So try to take the positive as well.
Yeah, great advice. All right, Kevin. So episode 3 here, our 5th and final question regarding career development. Do you have a basic checklist, we can call it, or a timeline of a couple different things students should do as they look to open their own practice after graduation?
I'm not going to run down an entire checklist of things. There's definitely a lot, right? There's like, you want to get your business name and save your URL quickly. You're going to have to register with the state, and you're going to have to get a tax ID number for the government. There's a lot of things like that. I'll kind of tell my story and what the time frame was, and then you can search AI, right, and look at what you could prompt that probably pretty well, and it's going to get very accurate. And then you might just need to fill in the holes a little bit. But for me, I remember I opened up my current practice in April 1st of 2010. I knew that I was going to be doing that January 1st of 2010. So I had a 3-month window. And in that period of time, I remember definitely getting the website designed and going, and the URL. Like, I really wanted to get a website, so make sure that happens. I did all the things like getting registered with sunbiz.org, which is Florida, and the tax ID. I got all that going. If you're going to be in network with insurances, okay, so that's a big animal to tackle. That is going to maybe take a little bit of a runway, and your practice may open before you are credentialed with a particular insurance, and you could just run that patient as a cash patient at that point, but let them know you're working through that, and the credentialing may trickle in. That's what happened with me. I definitely, you got to get your space locked in. I had my space locked in as of January 1st, which is when I knew. Okay. So you got to get that going, and what the dynamics of that's going to be. The equipment ordering, right? So depending, if you're opening up inside of a orthopedic office like I did, which had a lot of the furniture, fixtures, and equipment, I needed to get a table, I needed to get a computer, I needed to get a few things, wasn't too bad. If you're trying to outfit an entire office, there's going to be some lead time on that stuff, but you can, some things will trickle in. People are going to understand when you're opening up a practice what that's going to look like. But what I would be doing in that period of time, I think you can get this done in 90 days is what I'm saying, because I did. Is I was hitting the marketing up hard in the community. And one of the things I did that, looking back on it, really worked out was I knew about 10 people in Boca. It was about 45 to 50 minutes away from my previous practice I was leaving. So it was far where there wasn't like patients close to me. But I did have a few people that I knew from different things I had done. Like, I knew a golf pro up here. I knew a person that sold Juice Plus. I knew a few things. I grew up about 30 minutes away from the area, so there were some people I knew that were working here that I knew from college. And I asked to meet for them with coffee. I said, hey, I'm going to be opening up a practice in a few months in Boca. I really want to get kind of the lay of the land. Do you mind if I take you out for a coffee and pick your brain on the area? They love that. Like, that's a great idea. Met me for coffee, and I just wanted to, like, who should I meet? Are there any gyms in the area I should know about? Like, I just had some questions that I knew that person probably could answer and get me connected to the next person and then to the next person and go from there. And so I would start doing that in that window of time. But the more time, the better. You can get it done in 90 days. A lot of it's going to be depending on your lease situation. It's like the big thing. And it might take 6 months, but more the merrier, but you can get it done in 90 days.
Okay.
Now that you're getting a taste of understanding what ethical chiropractic business is all about, head on over to the Chiropractic Success Academy to check out our special student discount and continue your business development. You can visit CSA at csacircle.com to find out more.